One of the biggest problems that I face when I sit with my patients with hepatitis C is deciding whether or not to treat them today or whether to wait for perhaps some better treatments to emerge. We know that there are lots and lots of new exciting treatments that are going to become available over the next few years, and the question that causes me most concern is, when should I start treatment? What should I advise my patient to do? Here's how I look at it. I know that patients with chronic hepatitis C have slowly progressive liver disease. So I know that most patients are not going to get cirrhosis within 5, 10, 20 years even of infection. But when I see a patient, I don't know how long they've had the infection. I know that comorbid factors, HIV co-infection, I know that alcohol intake, I know that obesity accelerate disease progression. And that plays into my thinking. So from a purely liver perspective, if I'm seeing a patient in their 20s or 30s who has mild disease, was infected relatively recently, doesn't have any factors that might cause disease progression, I'm very comfortable advising them to wait for better therapies. On the other hand, when I sit with a patient who has clear evidence of advancing disease, so a liver biopsy or fibroscan showing something approaching cirrhosis, an F3 approaching F4 on the French Metavir system, those patients I would advise to get treated now. We do know that once a patient has cirrhosis, their lifetime risk of hepatocellular carcinoma doesn't go away even if we clear the virus. So if the patient has cirrhosis, we are committing them to a lifetime of ultrasound scans and a lifetime's anxiety. We know that all the treatments are slightly less effective in patients with cirrhosis. So my mantra is, I don't want the patient to get cirrhosis. So when I'm with a patient, I want to make absolutely certain that they're not approaching cirrhosis. I want to be absolutely certain that they have no comorbid factors. And only if those two criteria are satisfied am I willing to advise the patient to delay therapy. We're going to get this wrong. We'll never correctly assign every patient to the right treatment category. And I personally would rather overtreat patients and cure too many now rather than delay treatment in too many. So from a liver perspective, I'm dominated by a desire not to let the patient develop cirrhosis. But there are other factors that play a role in the way I approach this. I'm always worried about transmission. So young women who are considering pregnancy, in my view, should be a priority for treatment, because although the risk of mother-to-fetal transmission is low, around 5%, that for me is too high a risk. So for young women thinking of pregnancy, I'm very happy to treat early. Likewise, chaotic injecting drug users who are transmitting the virus to their peers, if we can persuade them to start therapy when they're engaged in treatment programs, that's a very good time to start treatment. So I would want to be treating those approaching cirrhosis and those patients who are transmitting. And the final group that I would think about treatment urgently are the patients who have other factors associated with their hepatitis C. Many patients with hepatitis C complain of fatigue, non-specific complaints that significantly impair their quality of life. For those patients, I'd be advising early therapy. So from my perspective, I want to offer the patient the best possible treatment as quickly as possible. From a health economic perspective, of course, there's a big incentive to delay therapy, because we know that the new drugs that are emerging will create competition in the marketplace and very likely bring the price of the medication down. So there is pressure from those people paying for treatment to focus our resource on those who need therapy today. I think that it's reasonable for us as doctors to work with our health advisors and our policymakers, but I do think ultimately we need to take responsibility and advise our patients on what's best for them, not potentially what's best for the insurance company. The final issue, of course, is the patient perspective. And in my view, it's the patient perspective that should dominate. This is not a pleasant thing to have, wandering around with an infectious virus, and if a patient really wants to get rid of their virus quickly, rather than delay therapy, then I'm very happy to do so. So in my practice at the moment, patients who've been waiting several years for therapy, who've been under careful surveillance, who've learned to live with their virus and have no other symptoms are very often willing to wait for next generation therapies in a few years' time. But new patients who are very anxious about the infection, new patients who want to clear the virus quickly, very often push themselves forward for therapy, and we're delighted to offer them treatment. That, of course, sometimes means starting patients on interferon-based treatments, knowing that there will be all oral regimes available in the not too distant future. That's a choice for an individual patient to make, and I never cease to be surprised at how many patients are so keen to get rid of their virus they'd rather start interferon today than wait for tablet-only treatments in 6 to 12 months' time. My final mantra, and I think the most important message, is we must never, never let our patients get cirrhosis. Whenever possible, whenever there are signs that the liver disease is accelerating, we should start treatment early, because once the patient has cirrhosis, you're then committed to a lifetime of cancer screening, a lifetime of anxiety.